Both the presenters done a lucid, wonderful presentation. And regarding GERD, we have more doubts to discuss day and day about certain things I would like to highlight here. See, actually, we have been tackling erosive as well as non-erosive. Among the scenario in that, non-erosive will be around 60 to 70% more common than your erosive disease. But when you're going to look into your erosive pathology, most of them will be coming into the diagnosis of function DI disorder. So we don't know what is the etiological factors for most of the time. And some patient will be having predominant of upper GI symptoms, and some patient will be having predominant of lower GI symptoms like your IBS and other things. And when you're going to use your PPI for a duration of time, there are many case reports, many patients who will be having worsening of your IBS. So at that point of juncture, what is your opinion to tackle that?
Philip, so sorry, what was the question? I missed out on the question.
So I'm not really sure whether I'm audible over there. So can you unmute that?
No, you're audible. I can hear you. I heard some comments, but what was the specific question about? You had a question?
So specific question will be regarding that most of the patient will be having evidence of GERD. So most of them will be having findings in favor of non-erosive reflux when you're going to do a endoscopy or other modality to diagnose. But we are using PPI for a duration of therapy. But some patients, most of them in one Indian scenario, will be landing the diagnosis of functional GI disorder. So most of them will be taking a PPI for a duration of therapy, and some patients may have worsening of your lower GI symptom like your irritable bowel syndrome. So in that kind of scenario, how are you going to tackle? So is it advisable to switch over to H2 blockers rather than combining? And we have been seeing most of the prescriptions nowadays with PPI, prokinetic, without assessing the clinical parameters properly. So what is your opinion in that area to tackle to prevent further worsening of IBS? Because most of the patients are reporting in day-to-day practice.
Yeah, okay, no, good question. I mean, I think we'll probably need a IBS expert here very soon. So, no, your point's very well taken, and I think part of the reason why we are talking about the use of acid suppressive medications, we should also be very familiar, just as you were pointing out, the abuse of acid suppressive medication. I'm quite surprised that a patient walks into a doctor's office with any question before you prescribe something. Does the patient really need it? Because once you give it, then the patient becomes very reluctant to stop it, whereas the medication is really not helping. So I would say is that we just have to be careful about the misuse of acid suppressive medications as well.
And one more thing from my side, sir, regarding when you're going to use PPI for a duration of time, as we have pointed out, there are a huge list of adverse events being reported nowadays. Starting from your head to foot, there are a huge list of adverse events. Starting from your major risk factors like your major acute coronary events like your MACE. So basic predominant pathway will be tackling on your DMPA, which means your arginine metabolism pathway. So at that point of juncture, most of the time the patients will be recommending your rabiprazole or something else to prevent that CYP interaction. So what is your opinion? So there are so many other adversaries, not only in that interstitial nephritis, bony complication, your fundic hyperplasia. In many centers, that too in remote areas in India, they have been using PPI for years together without knowing the response is there or not. So to that kind of patients, how are you going to assess the complication? As we all know, putting the patient on H2 blockers may risk tachyphylaxis and other things. But even then, H2 blockers will be having a significant impact of around 50 to 60% when compared to your PPI and erosive esophagitis, around 80 to 90% of response. But why can't we switch over to H2 blockers in that kind of scenario when you want to tackle it?
So yeah, I mean, there are multiple questions here, and I'd say I'd refer you to Dr. Sharat's slide on complications of PPIs that he used. I mean, I would say that there is a long basis. They will stop working after about 2 to 3 weeks. So if you want to use them on an as-needed basis, let's say on a Saturday or a Sunday, and not for the rest of the week, I mean, that's very appropriate to do so.
And since there is lack of time, one final question here. regarding H. pylori eradication, as what you have rightly pointed out, H. pylori eradication doesn't mean you're going to prevent your GERD. It's going to act on separate pathophysiology. H. pylori is going to be in peptic ulcer, separate pathophysiology. But even if you're going to treat your H. pylori by a triple drug or quadruple regimen, along with nowadays the trials have been going on with your dual release preparations of PPI, along with your high dose of PPI. So all those things, even then, the response rate is not been that adequate to control your reflex rate. So what is your opinion in that area, sir?
Again, what was the specific? I hear you made a number of comments, but what was the specific question? Sorry, I missed that.
So the specific question is H. pylori eradication. What is the role of giving high dose PPI, like when you're going for pantoprazole of 80 milligrams or dual release preparations at that point of time? So what is your opinion that you can do for H. pylori eradication? Nowadays, even more papers are there to validate that.
Yeah, so I think the reason to give acid suppressive therapy for H. pylori eradication is so that the antibiotics can work much better. So that's the reason to do it. It has nothing to do with suppressing the acid for GERD. It is to allow penetration of the antibiotics for the H. pylori. So I think that's the reason to do that, and acid suppression is good in that situation. But thanks, Chennai. I think great question. Appreciate it.
Thank you so much. So let's move